Okay, today we're going to talk about exercise stress testing. So the first thing with exercise stress testing is the history and physical assessment, and this is where it's really important that you take a very good history of your patient. So you want to include past history of heart disease, any medications that they're on, any interventional or surgical procedures that they had done. So it's very important to get a good history because you want to look for any underlying issues before you would walk them on a treadmill. So when we do a stress test, we take a resting blood pressure and a standing blood pressure, and we do that because we want to see if there's any discrepancies when they go from sitting to standing. We'll do their pulse, respirations, and we get their weight and height, and we also do a resting and standing EKG to compare the two, again, to see if there's any discrepancies when they go from lying down to standing up. So indications for exercise stress testing. So this is reasons why we do a stress test. So if we know if a patient has angina or CAD, if we suspect that they have angina or CAD, assess cardiovascular functional capacity. Sometimes patients get induced cardiac arrhythmias when they exercise. Sometimes patients go to cardiac rehab, and we want to send them to the stress testing area to evaluate the response to conditioning and prevention programs, and to evaluate the response to treatment such as medication, or if they had a procedure done in the cath lab, or if they had open heart surgery. So, and we do that because we want them in a controlled environment when they start to exercise again. Contraindications: if someone has a systemic or pulmonary embolus, you wouldn't want to walk them on a treadmill. That clot could break loose and they could have a stroke or an MI. If they have inflammation in the veins in their lower extremities, it may be difficult for them to walk. Significant aortic stenosis, you wouldn't want to walk somebody on a treadmill with AS. The valve is already tight and you're causing them to increase their blood pressure, increase their heart rate. So if somebody does have aortic stenosis and you walk them on a treadmill, the worst outcome is that the patient could die. So if you do hear anything, if you listen to the patient's heart sounds when you're doing your pre-assessment and you do hear anything, then we would let the cardiologist know so they could assess that patient. And really with significant aortic stenosis, this is why it's really important that you take a really good history of the patient, because sometimes patients do not know that they have AS. Congestive heart failure, that would be a contraindication because they're already in heart failure. So if you walk them on a treadmill, it's going to make their condition worse. If somebody's having an MI, they would come right to the cath lab. We would not waste any time doing a stress test. If the patient is not feeling well, if they have a non-diagnosed heart block, if they did have a recent complicated MI, they might do a pharmacologic stress test. If they have an uncontrolled ventricular arrhythmia, you would want to get that arrhythmia under control before you would walk them on a treadmill. Acute infection, unstable angina, they would go right to the cath lab. And then the last one is if the patient is unwilling to give consent, then you cannot do the stress test. And if that would happen, we would get the cardiologist to come in and speak to the patient about that. Relative contraindications. Relative meaning it's really dependent on which cardiologist. Some will do the case, some will not. So unstable angina, typically they would go right to the cath lab. If somebody has arthritis or other neuromuscular disorders, it may be difficult for them to walk on the treadmill. If they have moderate valve disease, they may or may not do a stress test. And then if their blood pressure is significantly elevated, they would want to give them medication to get their blood pressure down before they walk them on a treadmill. So when you have a patient come to you, the rating of perceived exertion is what we use to evaluate chest pain and shortness of breath. So we tell the patient on a scale from 0 to 10, 0 is no pain, 10 is the worst pain ever. We have them rate their discomfort or their shortness of breath. So once a patient tells you their score, just make sure you repeat it back to them. so there's no confusion. And just remember with your patients that the pain assessment, that pain is very subjective. So if someone says they're having 10 out of 10 pain, it's not for us to make judgment on them. Some people have a higher tolerance for pain than others. So again, the pain assessment scale, they rate it on a scale from 0 to 10. And then with children and with patients who maybe cannot speak to you, we have them do the Wong-Baker FACES pain rating scale. So there's 6 faces, and here's a picture of it. And you can see it goes in 2 increments from 0 to 10, and they point to which face rates their pain. The New York Heart Association Functional Capacity Classification Chart. This goes from class 1 all the way to class 4, and this is how we classify our patients based on their level of physical activity. So class 1 through class 4. Class 1 is no limitation of physical activity, so they can go about their daily activity without any shortness of breath or chest pain. Class 2 is slight limitation of physical activity. Class 3 is a marked limitation of physical activity, and class 4 is unstable to carry on any physical activity without discomfort. So class 1 is hopefully all of us in this class. Class 2 would be, they used to be able to mow the lawn, and now they are starting to have limitation on their physical activity. Class 3 is marked limitation of physical activity. So this is a patient that can't even walk to the refrigerator without getting shortness of breath or chest pain. So the Bruce protocol chart was developed by Dr. Robert Bruce in 1963, and this is how we start the treadmill for the patient. So the starting speed is 1.7 miles per hour, and they start on a 10% incline, and every 3 minutes the speed goes up and the incline goes up. So at the end of every 3-minute stage, you take a blood pressure, and an EKG is automatically done at the end of each stage of the Bruce protocol. So blood pressure should go up with every stage. If it doesn't, it can be indicative of CAD. And typically, if a patient completes 3 stages of the Bruce protocol, that they do have a low risk for coronary artery disease. The modified Bruce protocol, this is just an FYI, treadmill starts out horizontal, so there's no incline. So the first few intervals, the grade of the treadmill increases, but not the speed. And the Naughton protocol is a graded treadmill test, so speed remains constant, and the grade of the treadmill is increased at 2-minute intervals. So they, depending on a cardiologist, if they want to use one of the modified versions, they will let you know this ahead of time. METs, metabolic equivalent of a task. So 1 MET is the oxygen consumed by the individual at rest. So basically a MET is the amount of energy that we use. And we can quantitate the METs of a patient during their treadmill test. So then there's a chart here, 1 MET, 2 METs. 4 METs equals about 4 miles per hour on the treadmill. And the example I have here is 4 METs is 4 times the amount of oxygen consumption. So 10 METs is as good a prognosis with medical therapy. Its clinical significance is that someone who is able to work at that level of exertion will respond similar to medical therapy versus bypass surgery. 13 METs would be excellent prognosis. 16 METs is an aerobic master athlete, and 20 METs is excellent. So the higher the number, the harder you are working. Energy of swimming is 6 METs. So this means you use 6 times more energy than if you were to lie down and rest. And then this is just an FYI slide for you guys to see different activities and the amount of METs that we use. And then the double product This is just, again, informational because this showed up on the national exam if you guys choose to take it. But the double product is used as an estimate of myocardial work. So when you figure out the double product, you just take the systolic blood pressure times the heart rate and then the product of heart rate and systolic blood pressure. So that's how you get your double product.